find in the ICF, you will find like small amounts of sodium, calcium chloride, um, chloride, bicarbonate ions, proteins, phosphate. You know, those are all things that you will find in the ECF fluid. But keep in mind that potassium is the most abundant cation that's found in the ICF. And then you have extracellular fluid. This is your ECF fluid. This is the fluid that is found outside of the cell. Okay. So ECF fluid, the most abundant cation in the ECF is going to be sodium, Na plus. And we're going to talk about sodium and potassium a lot. And so that's why I kind of emphasize where, they are located, because those two ions, they control a lot of things that will occur in the cell. Sodium is most abundant in the ECF. Along with, you're going to find other things that you find in the ECF. You will find potassium, you will find magnesium, calcium, phosphate, bicarbonate. Those are just some examples of things that you will find in the ECF. But the most abundant thing there is going to be your sodium, okay? Another type of ECF fluid is going to be your interstitial fluid or your tissue fluid. This is the fluid that's found in, the small spaces between the cells. And we'll talk about this particular type of fluid a little bit more when we talk about edema. Because edema, this is excess fluid that's in your tissue spaces. Your plasma. Plasma is also a type of ECF fluid. Plasma is the is the fluid that your red blood cells are basically suspended in. And then we have what we call transcellular fluid. This is your fluid that's in your small spaces. Is also a type of ECF fluid. So this gives you, it gives you a look at, what I'm talking about. So this is plasma here. It's a type of ECF fluid. And then you have your intracellular fluid or your interstitial fluid. This is the fluid that is found in your tissue spaces. And then we have your ICF fluid. You see here is pointing to the inside of the cell. That's the fluid that's on the inside of the cell. Most of the fluid in the body is going to be in the ECF. This is where so I want to talk about a few things: passive and active, passive transport. So because in this particular chapter, we're going to look at the movement of water. And so movement of water is a passive transport process and involves osmosis. So we want to kind of talk about a little bit of passive transport, diffusion, and osmosis are the two things that we want to kind of talk about a little bit more. So diffusion, this is just the movement of a substance from an area of high concentration to low concentration. So things that can freely move like this are going to be oxygen, carbon dioxide, and any lipid soluble substance like some of your hormones. One thing, when it comes to diffusion, this is just the movement of your solutes. And solutes, this is the substance that is dissolved in water, and water is usually your solvent. Okay, so say for example, on this slide we have we have the water in the beaker, and you have like the little dots. So the red dots, this is your solutes, and the blue dots, this is your water. Keep in mind your solutes is that substance that's dissolved in water. Examples of solutes would be things like, as I mentioned here, but then also things like sodium, potassium. These are all considered to be solutes as well. Glucose, these are all solutes that are in the actual body fluid. So what's going to happen is, in just simple diffusion, the solutes are going to move from an area of high concentration to area of low concentration. So in figure 2, you see how the solids have moved to side B, and then you in figure 3, where after 3 hours, as far as the time, you see how now the solids have moved to side B, and you see how it's balanced. So the solids will keep moving until you reach equilibrium. Osmosis is a little bit different because osmosis is the movement of water. And keep in mind with osmosis, it's the water that's moving and not the solids that are moving. Okay. So it's the movement of water from a place of high water concentration to a place of low water concentration through a permeable membrane. Another way that you can define osmosis is the movement of water from a place of low solute concentration to a place of high solute concentration. So keep in mind that water is going to always move to where you have a higher solute concentration. So where you have more solutes, this is when water is going to always move in that direction. So once again, a second way you can define osmosis is the movement of water from a low solute concentration to a place of high solute concentration. Because if you have low solutes, you're going to have more water. If you have more solutes, you're going to have less water. So if you look at this, so my solutes are my little purple dots again, and then my water is my blue. As you see, you have more solutes on side A than you have on side B. So water is going to diffuse through this membrane and go from side B to side A, because now the water is moved from a place of low solute concentration to a place of high solute concentration. And talking about water, we got to talk about our three environments where you will find water: hypertonic, hypotonic, and isotonic. So let's discuss these. Let's start with your isotonic environment. Cells always want to be in an isotonic environment because this is where you won't have any movement of water. Okay. So your cells always want to have this balance. Okay. So figure A gives you an example of a cell that's in an isotonic environment. I think a definition for an isotonic environment: this is where your solute concentration outside the cell is equal to the solute concentration inside of the cell. Okay. So if your solute concentrations are equal, you're not going to have any movement of water. Figure B shows what happens when you place a cell in a hypertonic environment. So hypertonic says that your solute concentration outside the cell is greater than your solute concentration inside the cell. And so what's going to happen is water is going to move from the ICF to the ECF, and it's going to cause the cell to shrink. Okay. So you don't want this to happen. You don't want to have more solutes outside the cell, because it's going to cause the water to move from the ICF to the ECF, and the cell in turn is going to shrink. And then we have a hypotonic environment. And so this last image gives you an example of what happens with a hypotonic environment. The cell is going to swell. Okay. So in a hypotonic environment, water is going to move. Definition wise, your solute concentration inside the cell is greater than your solute concentration outside the cell. So what's going to happen is the water is going to move from the ECF to the ICF this time, and it's going to cause the cell to swell and burst. Okay, so you don't want to put your cells in a hypotonic environment, because this will cause the cell to swell and burst. And when cells die, tissue shut down, and then organs shut down, and then the person could die. A good example of placing cells in a hypotonic environment is water intoxication. So this is when a person drinks excessive amounts of water in a short period of time. So what's going to happen is, if you have water intoxication, it's going to dilute the solutes that are in your ICF. So now you're going to have more water there, versus solutes. And so now on the inside of the cell, you still have more solutes. And so what's going to happen, water moves from the ECF to the ICF and can cause the cells to swell and burst. So let's look at fluid exchange. Fluid exchange, and I'm going to stay here on this picture for a while, but you can follow along with your slides after this if you printed them out. But I'm going to stay on this picture for a while because this is going to help explain the actual fluid exchange that's going to happen in the cell. So this is an example of a capillary bed. Okay, this is a capillary bed that's associated with all cells. And so what do you find in a capillary bed? You're going to have this arterial end here. So this will be my artery, and then you have this venous end on this side. This is my vein, okay? And then in the middle you have your capillaries. Remember that your capillaries, they have the thinnest walls of all your blood vessels, and your capillaries this is where you're going to have the fluid exchange between the blood and the cell. So the fluid exchange, when you're exchanging fluid with the cell, this is going to provide the nutrients that the cells will need to survive. So you see intertwined in this, you see this lymphatic vessel. So all capillary beds will have this lymphatic vessel associated with it. And then you have like these, you see your cells that are here, okay? And so let's talk about the functioning of each end of this. So on the arterial end, you're going to have two main processes that have to take place in order for you to have fluid exchange. You got to have filtration and you got to have reabsorption. So on the arterial end of this capillary bed, this is where you have the filtration. So this is where, the body is filtering out the nutrients, is filtering out the fluid so it can get to the cell so they can carry out their function. So you have filtration. And then on the venous end, sorry about that. Then on the venous end, you're going to have reabsorption. So reabsorption basically is basically saying that it's going to reabsorb any excess fluid in that tissue space. So reabsorption says you're pulling the fluid back inside of the actual capillary. So you won't have a buildup of fluid here. And then I mentioned the actual lymphatic vessel. So the actual lymphatic vessel is here because the lymphatic vessel is going to reabsorb anything that wasn't reabsorbed on this venous end to ensure that you don't have any excess fluid in the capillary space. So, but also remember that your actual lymphatic vessels, they drain back into the venous circulation, so that fluid is going to still get back into your circulating blood volume. So remember that on the arterial end, you're going to have filtration. On the venous end, you're going to have reabsorption. Your capillaries, this is where you're going to have your fluid exchange. And then your lymphatic vessels, they're going to pick up any fluid that wasn't reabsorbed by the venous end. So this is going to ensure that no fluid is going to build up. And I don't know why this thing keeps doing this. So let's talk about what happens in the fluids that are associated with each end, okay? So on the actual arterial end, let's talk about the fluid exchange. And so she talks about the fluid exchange on page 163 and the pressures that are involved. There are two pressures that are involved on the arterial end. You're going to have your blood hydrostatic pressure, and then you're going to have your interstitial fluid osmotic pressure. So your blood hydrostatic pressure that's the pressure that's created on the inside of the blood vessel, okay? Your blood hydrostatic pressure is nothing more than your blood pressure itself. And keep in mind, blood pressure, this is the pressure that your blood places on the walls of your arteries. So your blood pressure is basically going to force fluid outside of the capillary bed so that fluid can get to your cells. Okay. Now you have a small pressure that's outside of the capillary bed, and that is called your interstitial fluid osmotic pressure, your IFOP. So this is the pressure that's outside the capillary bed, um, and it's basically helping to pull fluid out. So this pressure is created by proteins that have leaked into the interstitial spaces. And then on the venous end, the pressure that creates the greatest force to pull fluid back in is going to be your blood colloid osmotic pressure, or you can call that BCOP. Your blood colloid osmotic pressure is created by plasma proteins. Plasma proteins, these are proteins that are created in the liver. And once they're created in the liver, they're placed in the actual bloodstream, and from there it creates your blood colloid osmotic pressure. The most abundant plasma protein is going to be albumin. So albumin is going to make up the bulk of those proteins that will create your blood colloid osmotic pressure. And so what happens is your BCOP is on the inside of the capillary bed, and in turn, it's going to help to pull fluid back in on the venous end. Also, you have a small pressure that's outside on the venous end, and this is called your interstitial hydrostatic pressure. This is the pressure that is created by the fluid in the actual tissue spaces, and it's pushing on the capillary bed on the venous end to help to push fluid back in. And then, of course, you have your lymphatic vessel. So any fluid that was not reabsorbed on this venous end, the lymphatic vessel is going to come along and it's going to reabsorb it. Okay. In turn, that's going to keep any excess fluid from building up, and you want this process to happen, just like I have discussed. And this gives you just the names of the pressure, what happens, what's involved. So now, what happens when you don't have appropriate fluid exchange? When you don't have appropriate fluid exchange, you're going to have the buildup of excessive fluid in your tissue spaces, and that is a condition that's called edema. Okay, so the causes of edema, you have four main causes. You have increase in blood hydrostatic pressure, decreased blood colloid osmotic pressure, increased capillary permeability, and obstruction of lymph flow, which is called edema. But each of these causes, they have things that will cause them to happen. So let's look at each one. So our first cause is increased blood hydrostatic pressure, or increased BHP. Okay, so the common cause of this of increased blood hydrostatic pressure is going to be an increase in your vascular volume or an increase in blood volume. Okay, so remember that I said that blood hydrostatic pressure is created by your actual blood pressure itself. So anytime the blood pressure increases, that's going to force more fluid into those tissue spaces. Okay. Um, Another cause of edema is decreased blood colloid osmotic pressure. A decrease in blood colloid osmotic pressure is going to inhibit the ability for the capillary bed to reabsorb fluid on the venous side. Okay, so what can cause this? One, you can have an abnormal loss of your plasma proteins, or two, you're not producing your proteins, so you're not producing enough of your plasma proteins. So keep in mind, your plasma proteins, they are produced in the liver, they're placed in the blood, and they cause the reabsorption that's going to happen on that venous end. Remember that the most abundant plasma protein is going to be albumin. So let's look at two things that will cause the loss of plasma proteins. Um, One thing that can cause the loss of plasma proteins is going to be kidney damage, with kidney disease, because normally your kidneys, they're going to reabsorb your plasma proteins, but in a person with kidney failure, the kidneys are not going to reabsorb those plasma proteins, and you will lose them in your urine. Another thing that can cause the loss is going to be when you have large areas of the skin that have been damaged. Like, say, for example, when you have large areas of the skin to where you have a burn. When you burn the skin, you're damaging the cells, so what's in is going to come out, and blood vessels. Um, so those blood vessels are damaged, and so the fluid leaks out of the blood vessels, and you lose them that way. As far as production, when you're not producing enough plasma proteins, there are two things that are associated with that. One is going to be liver failure. Remember that our liver produces our plasma proteins. So if your liver is failing, you're not going to be able to properly synthesize the plasma proteins that are needed by the body. Another thing that can cause lack of production is going to be starvation and also malnutrition. Plasma proteins, that's just what they are. They are proteins. Proteins consist of amino acids. If you're in starvation mode or if you're malnourished, you're not taking in the necessary nutrients to get the amino acids that are needed to produce the plasma proteins. So with all that, that's going to decrease your blood colloid osmotic pressure, and that's going to decrease the reabsorption that should happen in the capillary bed. So increased capillary permeability. Remember when we talked about the inflammatory response, we talked about how the capillaries, they are going to basically dilate, and so when the capillaries dilate, that increases the actual permeability, and more fluid is going to leak out into the cell. And then we have obstruction of lymph flow. Anything that is that can block the actual lymph channels or the lymph vessels. So when those lymph vessels are blocked, the lymph fluid cannot flow through them freely, and it leads to a type of edema that's called lymphedema. And so with the blockage in the lymph vessels, they cannot reabsorb the fluid, so that any fluid that's left there, it stays in that tissue space, and it causes edema to happen. So manifestations of edema, okay? So manifestations of edema, some manifestations can be life-threatening and some are not. So life-threatening types of edema can be like edema that's associated with the brain. You have excessive fluid on the brain. That's going to, that's going to interfere with normal brain function. Can have excessive fluid in the lungs that can inhibit with the person's ability to exchange gases, to inhale and exhale. Those are just examples of life-threatening forms of edema. Now, when you have edema in like your joints, this is non-life-threatening, but it does decrease the ability of the joint movement. Edema can cause swelling of the ankles and feet. This is not life-threatening. But however, this could create problems with, wearing your shoes and things like that. Edema can compress blood vessels. So if the blood vessels are compressed because of the excess fluid, this decreases the blood flow and it causes ischemia. Excessive fluid between the blood vessel and the cells, this is going to increase the distance for your nutrients to diffuse from the blood to the cells. Now, another thing to remember is that whenever you're retaining fluid in the body and you have like this excess fluid in the body, fluid is going to cause the person to gain weight. So for every liter of fluid that the body retains, a person can gain 2.2 pounds. So, this is why, when a person like has congestive heart failure, or just say congestive heart failure, a condition like that, what happens in congestive heart failure is the body is retaining all this fluid in the body, and that's why the person will gain so much weight because of the retaining of the fluid. So one type of edema that I kind of want to point out is called dependent edema. So dependent edema, this is edema that's in your dependent structures of the body. Like say, for example, your feet is a dependent structure in the body. So what causes dependent edema is just gravity, you know. And when you're like, say, for example, a person's on their feet all the time, they may have swollen feet at the end of the day. That's what we call dependent edema. And what causes that is just basic gravity, and gravity increases your blood hydrostatic pressure. Okay, and so dependent edema can be caused by something as simple as just standing, or even sitting for long periods of time without moving your limbs. If a person doesn't have any pre-existing conditions, the best way you can, one way you can treat it, and I won't say the best way, one way you can treat it is just by elevating your feet, after you've been standing for a long period of time. Or you can wear like compression stockings and sleeves to where this doesn't happen. So how do you treat edema? You can do like a visual assessment of the person to where you can actually, when a person has excessive fluid, if they have edema in their feet, you can usually see it. You can see that the feet are swollen because they have this excessive fluid that's in the body. You can do like the finger pressure test. The finger pressure test, if you look on page 166 in your textbook, this is when they take the finger and they compress it into the tissue, and when they remove the finger, it'll leave behind this little pit, okay? And that's what we call pitting edema, to where you leave behind this little pit after you remove your finger. You can take measurements. You can measure the ankle and the feet and things like that. You can check a person's weight because, like I said before, for every liter of fluid you retain, a person will gain 2.2 pounds. Other treatments will be giving the person a diuretic. Diuretics, this will, cause this will decrease your ECF fluid. So basically what happens is it's going to increase your urine output, and that excessive fluid the person is going to lose in their urine. You can you can measure their serum albumin levels. So you can measure the actual albumin, and if those levels are low, you can get a better understanding as to why they have edema. But then also keep in mind that albumin is a plasma protein that's created in the liver, and this could kind of give a person some the physicians insight into they could possibly have liver damage as to why they have edema. But if the serum albumin levels are low, you can give a person albumin, and that will increase their blood colloid osmotic pressure. But measuring that level can kind of give you some insight as to what's going on with the person's liver. Um, you can you can elevate your feet if you don't have any pre-existing conditions, and if you're experiencing edema at the end of, say, a long work day, you can elevate your feet and you should be fine. But then also you can elevate your feet as well if you have other conditions, because that will help to um, you know decrease the edema that could be happening. You can wear compressive stockings. This will decrease the edema that can be associated with sitting for long periods of time, standing for long periods of time as well. So now we want to look at total body water. So if you flip in your textbook on page 168, it gives you an example of, total body water. So total body water, this is just the amount of water that, you have in the body. The body is like 2/3 water. So roughly between about 60%, about a little over 60% of the water of your body consists of water. And so you have a difference in total body water depending on, what man versus woman, and then also how much adipose tissue you have. So if you look on page 168, you see two people there, and both of those images, the person that the image is going to represent, they both weigh 220 pounds, okay? But you see the person on the left has a total body water of 60%. Person on the right has a total body water of 30%. But but the person on the right has more adipose tissue. So the more adipose tissue you have, the less body water you have. And so the less adipose, I think I just said that backwards. So the more adipose tissue you have, the less water you have in the body. So the more the That's right. So, and then also the more lean tissue you have, the more water you're going to have in the body. So the person on the right has more adipose tissue, so they're going to have less water. And the person on the right has more lean tissue, so um, they have more water. So as far as how does that compare with men versus women and infants? So men tend to have more total body water because men have less adipose tissue. So for a normal healthy man, their total body water is about 60%, but this will decrease in age to about 50% as a person will age because the more you age, you lose muscle mass and you have more adipose tissue. For women, a normal healthy woman, they have about 50% total body water because women have more adipose tissue than men. So the more adipose tissue you have, the less water you're going to have in the body. And then also, this number will decrease in women to about 40% as we age because as we age, we get more adipose tissue. And then in infants, in a full term infant, so about 80% of their body is mostly water, and most of that water is like in the actual ECF compartment. So usually, by when the baby reaches about age 2, you will have that balance in the water, whether it's male versus female. So how much water should you consume every day? You should consume 100 milliliters per 100 calories of water per day. Okay. So this is going to help you to metabolize your nutrients. So say for example, if you consume 1,800 calories a day, so that should be 1,800 milliliters of water, which is 1.8 liters. If you consume 3,000 calories per day, you should drink 3 liters of water. So that's going to help you to properly metabolize your nutrients and allow you to eliminate waste in the body. So sources of water gain. So how do we get water in the body? Mainly through oral intake. So the your oral intake from the liquids that you drink and the foods that you eat. Plus a lot of your foods they contain water. Your fruits, your vegetables, they contain water. And then like the water that you drink, and then even the other beverages that you drink, they do have like water in them. Metabolism is going to produce anywhere from 150 to 350 milliliters um, during your aerobic process. And remember, you produce water during glycolysis. And then from your tube feedings, if a person is on some type of, being fed through a tube, this is how they're going to get their water in the body. Sources of water loss. So the main way that you lose water is going to be through your kidneys and your urine. That's the main way you're going to lose them. You lose water through the skin, sweating. If you sweat a lot, sweat consists of water and also other things. So you lose water that way. Through your lungs, through the vapors in your lungs, and then also through your GI tract because your feces will contain a small amount of water. So I just mentioned about how much water you should drink per day. So it's based on the number of calories. So for every 100 calories, you should consume 100 milliliters of water. So you have this term that's called obligatory water loss. So water loss, or you can say urine output. So this is the amount of water that you're going to lose every day, regardless of how much water you consume. And so this is the water loss that has to happen to get rid of the waste products that are in the body. And then you have insensible water loss. This is water loss that cannot be measured, water loss that you are not aware of. So this is the water loss through like your respiratory tract, for example, because you cannot measure, the water vapor that is coming from your lungs. So now we're going to the last part of this, we're going to look more so, a little bit more so at sodium and then water and what is going to regulate those things. So let's talk about sodium. Sodium is the most abundant cation in the ECF, and sodium has a few functions that I want to mention here. Sodium is going to regulate your ECF osmolality. The term osmolality is a term that you should put in your vocabulary. And osmolality is nothing more than a concentration of your solutes or that particular solute in the actual ECF. So you're going to hear me mention a lot in this chapter osmolality. Sometimes I'll say osmolality. Sometimes I will say concentration. Keep in mind that your osmolality is your solute concentration. So since sodium is the biggest cation in the ECF, it's going to make up the bulk of that ECF osmolality. So if you start to lose sodium in the body, that concentration will go down. If you start to gain sodium in the body, that concentration will go up. So that ECF osmolality is controlled a little bit by sodium. Sodium plays a role in your acid-base balance, and we'll see that when we talk about acid-base disorders. Because sodium can bind to bicarbonate and form sodium bicarbonate, which is a part of a buffering system. Sodium is needed to depolarize your nerve impulses. If you remember anything from A&P, your nerve impulse has to depolarize and has to repolarize. And in order for it to depolarize, you need sodium for the nerve cell to depolarize. So those are just a few functions of sodium that can in the body. So sources of sodium gain. So how do we get sodium in the body? We get sodium in our body mainly through our diet. Even though the body only needs 500 milligrams per day, we consume more than that per day. So you get your sodium through your diet. Another way that we get sodium in the body is through IV solutions. So a lot of times when you see people in the hospital, they may be hooked up to a sodium chloride IV. And then also medications. Medications will oftentimes contain sodium chloride. So how do we lose sodium in the bodies? The kidney is the main regulator of sodium. So say, for example, when you have high levels of sodium, the kidneys are going to excrete sodium in the urine. But then when you have low levels of sodium, the kidneys are going to reabsorb more sodium and keep more sodium in the body. And so this excretion and the reabsorption of sodium is tied in with the actual blood volume, because anytime, if you have an increase in blood volume, what's going to happen is the body is going to excrete more sodium because water follows sodium. So when the water leaves, that's going to bring your blood volume back to normal. If you have a decrease in blood volume, the body's going to reabsorb more sodium. And so water always follows sodium, and so that's going to put more sodium into the actual blood volume. So blood volume and sodium, they're closely linked to each other. You can lose sodium through the GI tract, like if you vomit, you have diarrhea. If you have a gastrointestinal suction, those are all things that can that will control sodium. And then through your skin, because when you sweat, you lose sodium from the body. So what regulates sodium? Sodium is regulated by the sympathetic nervous system. Excuse me. And so this is how it gets tied in with the actual, blood volume. So the sympathetic nervous system is going to regulate sodium levels. Okay, so you have special receptors that are found in the blood vessels that are called baroreceptors. So these receptors, they keep an eye on blood volume and things like that. So one thing I want you to remember is here, if you have an increase in blood volume, that leads to an increase in blood pressure. If you have a decrease in blood volume, that leads to a decrease in blood pressure. Those two things go hand in hand. And if one goes up, the other one goes up. If one goes down, the other one goes down. So how is this tied in with sodium? Okay. So if you have an increase in blood volume, you have an increase in blood pressure. The body's going to always want to maintain a normal blood pressure. So what's going to happen is with that increased blood volume, increased blood pressure, you're going to have the increased excretion of sodium by the kidneys. So basically what happens if you start to lose sodium in your urine, water follows sodium, and when that water follows sodium, that helps to bring your blood volume and your blood pressure back to normal. So if you have decreased blood volume, that leads to a decrease in blood pressure. These receptors will sense that, and so what's going to happen is you're going to have decreased excretion of sodium by the kidneys. So your kidneys are going to basically reabsorb more sodium. So when the kidneys reabsorb more sodium, water is going to follow. That brings your blood volume back to normal, which in turn brings your blood pressure back to normal. So in talking about, decreasing in blood volume, we have to talk about the RAA pathway. The RAA pathway stands for your renin, angiotensin, aldosterone pathway. So this is a pathway that is activated because you have a decrease in blood volume. So the kidneys get a percentage of the blood, and of the actual blood flow. I think it's about 10% that's pumped from the heart. So whenever the kidneys have a decrease in the actual blood flow, it's going to activate this pathway. So decrease in blood volume is going to lead to the activation of the renin, angiotensin, aldosterone pathway. And so this pathway is on page 424 in your textbook, but this is the picture of the pathway that's here. This is the pathway that you need to remember, okay? So whenever you have a decrease in blood volume, the kidneys are going to recognize that, and the cells of the kidney are going to produce the enzyme that's called renin, okay? So renin is an enzyme that's produced by the kidneys when you have a lack of blood flow that activates this pathway. So renin is going to convert the plasma protein angiotensinogen into angiotensin 1, okay? So what happens is when the kidney produces renin is going to convert angiotensinogen into angiotensin 1. So then angiotensin 1 is going to travel to the lungs where it's converted by an enzyme to angiotensin 2. And then angiotensin 2 is going to go two places. One is going to go to your arterioles or your arteries. It's going to cause vasoconstriction, and that increases your blood pressure. But then it can also go to the adrenal cortex, where it's going to cause the production of aldosterone, okay? So aldosterone is a hormone that you have to remember because we're going to talk about it so much more. So get in your mind what aldosterone is going to do. Aldosterone is going to cause the reabsorption of sodium. So once sodium starts to reabsorb, water is going to follow. That's going to bring that blood volume back to normal, and in turn brings your blood pressure back to normal, okay? But there are other things that aldosterone will do. So as you're making your notes right next to aldosterone is going to cause the kidneys to reabsorb sodium, but it's also going to cause the kidneys to excrete potassium and hydrogen ions. That's the complete function of it. And so you need to remember that, because once we start talking about potassium, aldosterone is going to pick back up. So let's look at what regulates water in the body. So two things that are going to regulate water. One is going to be the thirst mechanism, and another is going to be your anti-diuretic hormone. Okay, so thirst mechanism and also the production of ADH are both triggered by changes in your ECF osmolality, so an increase in your ECF osmolality, and also a decrease in your blood volume. For example, um, increase in blood volume will lead to a decrease in the reduction of ADH secretion, and decreased blood volume leads to increased production of ADH. And that's a typo there. It should not be ADD, it should be ADH. And then also, increased ECF osmolality is going to put your cells in a hypertonic environment. And so, what's going to happen is when cells are in a hypertonic environment, they're going to shrink. It's because water is going to move from the ICF to the ECF, and that's going to cause cell dehydration. In turn, that's going to trigger the whole thirst. That's going to trigger the whole thirst mechanism, where a person is going to want to drink some fluid that contains water. And we'll talk more about this when we talk about ADH in just a few seconds. So what is thirst? Thirst is the conscious sensation to want to drink fluid, okay? So you want to drink fluid, mainly fluid that's high in water content. And so maybe you can kind of, think about this in times when you have been really thirsty. So if you have that whole thirst mechanism has been triggered, and say if you've been, if you want something to drink, and say if you drink something that has a lot of solutes versus water, after you drink that substance that has a lot of solutes, like maybe some type of, sweet tea or some type of soda, you still feel this need to drink water, because even though you drank a fluid, the fluid didn't have enough water in it, so it still didn't satisfy that whole thirst mechanism. So there are a few things that control thirst. One is going to be cell dehydration. Remember, we said when that cell is placed in a hypertonic environment, and a good example of that would be an increase in your ECF osmolality. So, that means that you have more solutes outside the cell. So water moves from the ICF to the ECF. And in turn, this is going to trigger that whole thirst mechanism. A decrease in blood volume. So meaning that the person is losing fluid from the body. So if you're just losing fluid from the body, that can increase your serum osmolality as well. And what's going to happen is the osmoreceptors in the blood, they can detect those changes in your serum osmolality. Increased levels of angiotensin 2. This is kind of a third mechanism, because if you have increased levels of angiotensin 2, that has resulted from the activation of the RAA pathway, and we know that pathway is activated when you have a decrease in blood volume. So we have a few types of thirst, a couple types of big categories of thirst. So your first category is hypodipsia. So hypodipsia is the decreased ability to sense that you are thirsty. This could happen because you have lesions in the hypothalamus, because thirst is controlled by the hypothalamus. That's where the whole process is controlled. And this could be a normal process that can happen as we age. And if you think about, if you have elderly grandparents, or if you have an elderly relative, oftentimes, they don't really drink a lot of fluid, or they don't eat a lot of food. So in turn, because as you age, you naturally lose the ability to sense that you are thirsty, and that's why a lot of elderly people run the risk of, being dehydrated, especially in the summertime, because they've lost the ability to sense that they are thirsty. Then we have polydipsia. Polydipsia is excessive thirst. That's just the overall general name for it. But then I kind of want you to add in your notes to kind of separate out a little bit, because she kind of lumps polydipsia in. But we have two types of polydipsia. One is going to be symptomatic or true thirst. True thirst, this is when you've actually lost fluid from the body and you want to replace that fluid. So true thirst can be caused by diarrhea, vomiting, diabetes type 1 or type 2 diabetes, diabetes insipidus. So in these cases, you've actually lost fluid from the body, but you want to replace, and your body's going to want to replace the fluid. So true thirst says you've actually lost fluid from the body. And then we have false thirst, or we have inappropriate thirst. So this is the thirst that a person will experience despite their body being properly hydrated. So a good example of this is congestive heart failure. What happens in congestive heart failure is like you've lost that circulating blood volume, but your body still has a lot of fluid, but that fluid is trapped in third space in your smaller cavities of the body. And then we have psychogenic thirst. Psychogenic thirst. This is the thirst that you see in your psychiatric patients, and so this is kind of a compulsive water drinking that's experienced by those patients when they're having some type of outbreak. So this and so in a person that's experiencing psychogenic thirst, they will drink any type of fluid that is available. So they will drink, dirty water. They'll drink toilet water. They'll drink anything that is a fluid because this is a side effect of, maybe the medication that they're taking, or something like that. So psychogenic thirst is generally experienced by psychiatric patients. And lastly, we want to talk about ADH. ADH stands for anti-diuretic hormone. So this hormone is synthesized in the hypothalamus and is stored in the posterior pituitary gland until the body needs it. Okay. So ADH, what this hormone will do is this is the hormone that will cause your kidneys to concentrate your urine. So in turn, it will decrease the amount of urine output you have every day. Okay. So when this hormone is not working properly, your body can lose large amounts of urine per day. So basically what happens when it's functioning correctly, it's going to cause you to lose anywhere from 1 to 2 liters of urine per day. But when it's not functioning properly, you can lose 10 times that amount of urine per day, of fluid per day from the body. So basically what this hormone is going to do is going to cause the kidneys to concentrate your urine. And so a good way of saying that, when you look at the functions of ADH, it's going to cause the body to retain water. Okay. So this hormone is going to go to the kidneys. It's going to act on the kidneys, and it's going to cause the kidneys to reabsorb more water. But then also this hormone can act on your sweat glands, and it can decrease the activity of your sweat glands and cause your sweat glands not to lose as much water or lose as much sweat. But it can also act on your blood vessels, because another name for ADH is called vasopressin, and it can cause your blood vessels to constrict. Okay. So what causes the secretion of ADH? Changes in blood volume and changes in your serum osmolality. Okay. So if you can, as you're listening to me, write these things down. Okay. So if you have an increase in blood volume, you're going to have a decrease in ADH secretion. Because keep in mind, if you already have an increase in blood volume, you don't need any more fluid in the body. So that's going to decrease the amount of ADH that's produced. If you have a decrease in blood volume, that's going to increase ADH secretion. Because with a decrease in blood volume, you have less fluid in the body. And so in turn, you want to retain some more fluid. So your ADH production is going to increase. An increase in serum osmolality. If you have an increase in serum osmolality, most often you've lost fluid from the body. So increases in serum osmolality is going to increase your ADH secretion. Decreased serum osmolality means that you're probably retaining fluid in the body. And so this is going to decrease ADH production in the body. Okay. So other things that can stimulate or inhibit ADH, one is going to be nicotine. Nicotine is going to cause the increased secretion of ADH. And then alcohol is going to inhibit the secretion of ADH. And that's going to end this part.